non-financial platform which is being created by Wipro to support all the clinicians to get a curated information in this time of COVID, so that it would be handy for them to treat patients better, and this can be percolated further. I would invite the panel, and I would request Dr. Usha to introduce the panel, and please take over. Thank you.
Thank you very much, Dr. Vijay. It's our absolute pleasure to talk about type 1 diabetes today. We all know that at this time of COVID, a lot of our patients are having difficulty accessing medical resources, and us doctors are also having difficulty keeping up with our CPD and our CME. And I think this is a great initiative connecting professionals. We have with us today Dr. K. Prasanna Kumar, who perhaps has one of the largest databases of diabetes patients in India for type 1, and has a huge network of clinicians working with him to provide care for type 1 diabetes. And he is, if anybody can tell us the practical realities of managing type 1 in India, that is going to be Dr. Prasanna Kumar. We also have Dr. Murali Ganguri, who Dr. Prasanna Kumar practices out of Bangalore, but has a network of type 1 clinics all over India. Dr. Murali Ganguri is an endocrinologist trained in the UK who currently practices in Vijayawada. He again has a special interest in type 1 diabetes, and he brings to us the expertise of training and clinical day-to-day problem solving. I am Dr. Usha Ayagari. I practice in Chennai, and I'm also an endocrinologist with an interest in type 1 diabetes. Now, between us, we're going to be covering a range of topics today. We're going to be talking to you briefly about the pathophysiology of type 1 diabetes and the myths, which we will start with Dr. Prasanna Kumar. Then Dr. Prasanna Kumar is also going to talk to you about management. So the practical realities of how to manage, how to start the insulin, how to not just initiate insulin, but how to procure insulin for the patients. All the practical realities Dr. Prasanna will talk us through. Then Dr. Murali will talk to us a little bit about hypoglycemia and sick day rules. And then I will take us through an introduction to carb counting and an introduction to technology. From our side, we're going to keep the presentation short because we'd ideally like to spend a maximum amount of time interacting with you, taking your questions and answering whatever are the day-to-day challenges that you face in type 1 diabetes management. I know that some people have more experience, but with the prevalence of type 1 diabetes being low in India, some of us have very little exposure. So here's your chance to talk to all of us and to pick our brains and to get as much information as you want about type 1 diabetes. With this, I hand over to Dr. Prasanna to introduce us to today's talk and to kick us off with the pathophysiology, myths, and then practical tips on management. Dr. Prasanna, all yours.
Dr. Prasanna, you are on mute. You have to unmute yourself.
Good evening, everybody. Thank you for being here. I'm grateful to Dr. Usha for a generous introduction, as well as giving me an opportunity to share some of my views and my experiences, or whatever little wisdom I have in management of type 1 diabetes. Instead of going to a didactic lecture on type 1, I'll put some of the myths that are there, so that how these myths are cleared as. Basically, right from etiopathogenesis, there are a lot of myths. One myth is among HCPs and even public also, all type 1 diabetic children, all diabetics which are seen in children are type 1 diabetes. And to the extent even IDF says does not matter whether you do a test or not, if below 16, we take it as type 1 diabetes. It may be all right for epidemiology, not so when you manage. I will tell you some of the examples. And type 1 diabetes is in only children below 20 years, not necessary. I had a 48-year-old lady, 53-year-old lady. She has been brought 15 years as type 2 diabetes. And it turned out to be type 1.
KMP.
And Regarding management, all type 1 diabetes children should be admitted to hospital at initial diagnosis for teaching, insulin technique, education, adjust the dose. All of them are wrong. In the last 10 years, I have more than 300 children. Not a single child I have admitted for diabetes management. Why? If you admit in a corporate hospital in Bangalore or Chennai, the cost is going to be 60,000 to 1 lakh. Everything can be done outpatient unless the child is sick or ketosis. All type 1 diabetes can be managed by 1 or 2 doses of premix insulin. Most of the doctors say, I give premix morning and night, they'll be well controlled. Other myth, Dr. Murali is going to talk. Hypoglycemia is very dangerous in children with diabetes. These are some of the myths with them. Then, all diabetic children will get complications sooner or later, whether you control or not. Diabetes will affect school performance in children. Type 1 diabetes or diabetes in children is homogeneous. Everything is same. Etiology is same. Pathophysiology is same. Progress is same. Complications are same. Treatment is same. Hypoglycemia is always preceded by symptoms. How is it a child does not have? He will have symptoms. There will be tremor, hunger, sweating, or drowsiness. Most important, pump. Everybody will ask, sir, shall I get pump? Once I get pump, no problem. What is the problem, sir? Once I put my child on pump, I don't have to monitor. Just fill that insulin pump, forget about it, just like scooter. And type 1 diabetes, I heard that insulin pump will do everything. It's a panacea for all. It will control diabetes without doing anything. And once you put the patient on pump, you don't have to worry. No need to check, no need to adjust the dose of insulin. Once insulin dose is fixed, it will not change. Sir, why is it so fluctuating? You just me the correct dose. Next 3 months, I will continue same. Next 1 week, I will continue same. Come back to you after 3 months. It is doctors and your problem. You have to, why did I come to you? You have to adjust my child's insulin. You have to manage it. You have to see diabetes is beautifully controlled next 50 years. Child will not have hypo or hyperglycemia. That's all what I am going to do. The reality is different. Starting from etopathogenesis, all diabetes in children is not type 1. I had a child in January coming from USA and they had admitted in a hospital and the child was treated with 4 doses of insulin, came to me. I got the GAD antibody negative. Then I called my colleague, look here, this is type 1 diabetes. 5% of them are type 1 diabetes B. That is autoimmune antibodies are negative, but still it can be type 1. After 2 days, I got C-peptide and it is 1.6. Then I told him, this is not at all type 1, it is type 2. The child is 10-year-old, no family history of diabetes. It was actually underweight. The child is from USA. They had come just 1 month before detected. They went back. Yesterday, they wrote to me, sir, I have stopped all insulin as by what? Now HbA1c is 6.6 and I have stopped all insulin, no tablet. I'm going to connect your endocrinologist from Bangalore who has now settled in New Jersey. So that is how even at 10 years, thin, it can be type 2 diabetes. No need to admit all type 1 diabetes, as I told you, unless they have diabetic ketoacidosis or sick. Children with diabetes can have quality and quantity of life as good as non-diabetic. 1980, when I was an MD physician working in Bangalore University Center, the first diabetic I saw was 20-year-old and he was a college student. He said, sir, my life is gone. I will not get married and all. I said, no, he'll control diabetes. He was on insulin, got married, he got children and I went to their marriage. Now he has got grandchildren also. Mind you, from 1980 to 2021, he does not have any complication, no retinopathy, no nephropathy, no cardiac involvement, absolutely all right. Worked 40 years as lecturer, professor, retired, registrar university, even now he's in Vidhan Saudha. To tell you that even diabetes can have a quality and quantity of life as good as non-diabetic. First diabetic child detected in USA. Lilly still has his photograph in Indianapolis and he died at the age of 85. He was 6-year-old. Most of you might have seen from 6 years to 85, that man lived 8 years. The first child who got insulin when it was found like that. So that is how it is. This is good news for all. All complications of diabetes can be prevented with good control diabetes. Many of them 40 to 45 years. Other day, Dr. Mohan asked me, do you have any type 1 with 50 years? I said, I don't have 50 years. I have 40 years, at least 2 to 3 of them 40 years. No complications. They are living well, 60 to 75 years age, and no problem. If diabetic never had hypoglycemia, that means they are never well controlled, because if you try to achieve a good control 7, definitely it will happen. If you have a Mercedes Benz and try to drive at 30 kilometers, you may not have accident. But why have Mercedes Benz? You can have auto rickshaw. When you have Mercedes Benz, you have to drive at 150 to 250 kilometers per hour on a highway. And when you drive at it, yes, accidents are bound to happen. Now, many people, as I said, they think, yeah, best thing is to give 2 doses of premix. Never, never do that. Type 1 diabetics means whether young or old or middle age, always basal bolus regime. You should give 3 doses of short-acting insulin before breakfast, before lunch, before dinner, and give 1 acting insulin after dinner or after breakfast, whatever time. But once you give basal bolus, the basal insulin should be given the same time of the day. You cannot give today morning, tomorrow afternoon, day after tomorrow night, whether it is after breakfast, after lunch, after dinner, before dinner. Fix some time and then give it. And many people think that the best insulin for all type 1 is insulin analog. It's not true. Out of 2,500 children, I am maintaining 53 places, starting from Karnataka to even Dibrugarh. I can only afford to give the human insulin. Human regular insulin is as good as anything. Only last few years we could get money. I could manage with the glargine, because the cheapest, most economical, affordable, acceptable basal insulin. Why? One is, at least when I give basal bolus and give glargine, I give glargine through pen for every child. Once the child takes this basal insulin, I tell them, for whatever reason, sometimes they get low sugar, they stop it. But once you give this basal, whatever reason, don't stop that. So if they take basal insulin once without missing, even if they miss bolus, they are unlikely to go to diabetic ketoacidosis. My admission out of 600 to 800 children was 30 to 40, 20 years back. I could not give glargine. Now, everybody getting glargine insulin pen and basal bolus. Not even 2 to 3 child is admitted with hypoglycemia or hyperglycemia. Hardly 1 per year out of 2,500 children. Scholastic performance, whether it is sports or whether it is school or arts, type 1 diabetic and children perform as well as non-diabetic. You know, there are examples in sports. I saw Wasim Akram 20 years back when he was 18 or 20. In UK, he started having polyuria, went to doctor, and today he must be around 45, still on basal bolus, doing extremely well. There are people who have even participated in Olympics. So also not, there are many people who are film actresses. You may not know their names also. Very famous one, they have type 1 diabetes. In fact, maybe even in USA also, that the one who got a Miss USA award few years back was type 1 diabetic. And everybody thinks type 1 diabetes is very homogeneous. All are same. Etiology, pathology, management, no. Type 1 diabetes is as heterogeneous as type 2 diabetes. Etiology, pathology, progresses, complication, insulin dose, manifestation, name, anything. I can give you examples that type 1 diabetes is as heterogeneous as type 2. Monitoring type 1 diabetes. People ask the question, how frequently to monitor? I said, it depends. How frequently you want to look at mirror? If you are bald, there's no point in looking at mirror, because neither you need a comb, nor you have to look at the mirror at all. Whereas if you are a film actress, every 10 minutes, you have to look at a mirror. There's no point in looking at mirror if you do not have makeup or lipstick or comb over hair. So the question is, as frequently as possible, whether once a day or 7 times a day or 100 times a day, depending on CGMS. More frequently you monitor, your control will be better. But it is not to stop there. More frequently you monitor, more frequently adjust the dose, it will be better. Pre-breakfast, pre-lunch, pre-dinner, post-breakfast, post-lunch, post-dinner. Remember, every type 1 diabetic should check once a week 2 to 3 a.m. blood sugar, and it should be more than 100, because if it is less than 100, the child is likely to get into hypoglycemia. Please ask everybody to have a glucose meter. It's called glucose meter, not glucometer. Glucometer is the trade name of AIMS. a company. So ask them to buy glucose meter, give them pen or syringe or insulin, and ask them to buy keto sticks. I don't know what you get. Previously, you get keto sticks, keto diastics, multi sticks, whatever it is. Ask them to have a ketone checking strips in the home. You can even check beta hydroxybutyrate today with some of the meters. If the random blood sugar is more than 50, ask parent to check ketone bodies. It is not just traces. If it is moderate or severe, please take to hospital. The subcutaneous insulin does not work, and treat the cause infection with antibiotic. Check for electrolyte, blood gas analysis treat. And most important, I said they think all hypoglycemia. No, beyond 10 to 20 years, they have autonomic neuropathy, hypoglycemia unawareness. They may not get drowsiness, tremor, sweating. Suddenly they go into unconsciousness. So insulin pump, the problems prospects are affordability and acceptability. And you have to tell every child and parent, diabetes is your disease, your child disease. Self-management is most important. Healthcare professional, doctor is going to help you to manage your diabetes well. Thank you for your attention. At the end, if there are any questions, I'll be happy to answer you.
Thank you very much, Dr. Prasanna. I am sure, I would really like you to tell the audience later on about, because the amount of experience you have in terms of helping people get insulin and manage their insulin is immense. So once maybe we come to Q&A, you can give them the practical tips in terms of how to practically manage these young children with diabetes, if that's okay. Excellent. In which case, I would like to invite Dr. Murali Ganguri. He's going to again take us through over the next 10 to 15 minutes about hypoglycemia, sick day rules, and a few other key management issues for type 1 diabetes. Dr. Murali, the floor is yours.
Can you hear me?
Yes, we can.
Yeah, doctor, you're clear.
Yes.
Okay. 1 second. It looks like my presentation has disappeared. Can you see the presentation?
Yes, doctor.
Yes, we can.
Thank you. So I'll be speaking about hypoglycemia and sick day rules. So I'm not going to discuss about what hypoglycemia is and the symptoms and signs. So we'll straight away get into the business. That's what is hypoglycemia. The thing is, the 70 milligrams per deciliter is taken as non-diabetic fasting patients where the counter-regulatory hormones response goes high, and also where you start seeing problems related to hypoglycemia in the long run. So that's why they've chosen that number. And 54 milligrams per deciliter and less is taken as severe, because that's when you may start having neuroglycopenic symptoms, which are more dangerous, like confusion, seizures, coma, that kind of stuff. And the biggest challenge for managing the type 1 diabetes is when you try to achieve this ADA recommended target of HbA1c, you start having problems about having hypoglycemia. So on average, you are expected to see at least 3 severe hypoglycemic episodes per 100 patient years. And this is the biggest limiting factor in terms of achieving the tight control. So according to many studies, it's not very common to see any diabetes related complications when HbA1c is above 7.6. So we don't have to be too strict about HbA1c. Intraday variation is also important, and most importantly, preventing hypoglycemia is extremely important, because this can be very, very stressful for the patient as well as the family. So we have to be a little bit, even ADA says that you safely achieve the HbA1c target. So people fixated on the HbA1c and try to forget this personalization and individualization of the target. They just keep on trying to achieve it, and this is going to cause a major problem. So how are we going to manage hypoglycemia? Most important is educating the patient and empowering the patient. So how are you going to do that? So you make sure in every clinic visit, you ask the patient whether they had any severe hypoglycemic episodes, how often they're having hypoglycemic episodes, how they have managed it, and if there was any gap in the way they managed it, address that, and making sure they carry some kind of kit where they have stuff that is related to treatment of hypoglycemia, like carrying some quick-acting sugars or liquids or chocolates for that matter. And another important thing is, when there is a hypoglycemia, there is this tendency to overtreat it. This is not going to help in the long run. So we have this seesaw kind of management where they have hypoglycemia followed by severe hyperglycemia, and then you keep chasing the tail. So that's not going to work. So it's very, very important that we don't overtreat the hypoglycemic episodes. And also we have to provide them the tools. So, I mean, there are poor patients where there may be problems in procuring some of these instruments, and then there are patients who actually can afford. So we have to offer them, and it's up to them if they can afford and choose the methods. CGMS can be extremely useful, and self-monitoring blood glucose, minimum I would recommend is 3, and occasionally 2 o'clock, 3 a.m. in the morning reading. And I usually target fasting reading and pre-lunch and pre-dinner readings rather than post-meal readings, particularly if you're using human insulins, because 2 hours post-meal, they haven't finished their job and they may have a hypo before lunchtime. So that is one thing when you're using human insulin to be careful about. A lot of people think insulin pumps are panacea, and it's not true. And some of them don't do carbohydrate counting, which my friend Dr. Usha is going to mention about. So Daphne principles and applying those principles is very, very important in preventing these hypoglycemic episodes. And even the same food, same insulin ratios can vary over a period of time, even in the same periods. For example, if the patient is at home on Sunday, it behaves differently. When he is at school, it behaves differently. So we may have to set the ratios for different days based on the kids' physical activity. So this is very, very important. And professional support. So this WhatsApp kind of support could be very, very useful. And once you train them for 2-3 months, they have learned it for life. So that's very, very important that we can provide that kind of support for these patients. And importantly, again, if the patient is able to afford, you could offer them analogs, which are very, very good, because particularly for kids, you have to give human insulins a bit earlier than when they're going to have a meal. But if it is analog insulin, for example, Fiasp, it can even be given after the meal. So, for example, if somebody is going to have 100 grams of carbohydrate and they have taken the insulin has gone in, and the kid did not have that 100 grams, and he's going to have a hypo. So in those in kind of situations where you could these analogs could be very, very useful. So you wait for the patient to finish their meal and see what he has eaten, and then give the insulin based on what he has eaten. So in that way, analogs could be very, very useful if they are able to afford. But most importantly, dawn effect. So there is a tendency to look at the fasting readings and keep on increasing the basal insulin. So that's not going to help for a patient who is having a dawn effect. So it's very, very important you occasionally check 2 a.m., 3 a.m. readings and find this dawn effect. And obviously, if somebody is able to afford CGMS, it will beautifully demonstrate the dawn effect. So, and most important thing, extremely important thing, which I have seen is the problem with the insulin administration. So there is a U40 concentration and U100 concentration, and there are patients who use U100 glargine and U40 actrapid. And I have seen patients using same syringe for both, and that is causing a major problem. Giving a U40, using the U40 syringe and giving U100 insulin can deliver 2.5 times the insulin. So that's not going to help, and it can cause massive hypoglycemia. It's very, very important you educate them. And this is where the empowerment and education comes into the action. And another thing is, every single visit, you examine the injection sites. You can see this patient. This patient is a pump patient. You can see how bad the pump is damaging her abdomen. And you give insulin, it's not going to work. and there is no linear absorption. Sometimes it does not get absorbed and push them into decay, or it can get really fastly absorbed and cause severe hypoglycemia. So it is a double-edged sword. So we have to be very, very careful and educate them and make them rotate the injection sites. And you could see this slide here, the U40 syringe, same insulin, U40 on the left side, U100 on the right side. And I've seen patients using U40 syringes, taking the pen pills and taking the insulin from the pen pills and giving it. So it's a really, really dangerous kind of practice. So you could see this U40 syringe and U100 syringe. And again, this is a pen probably safest in terms of calculating the dose. But however, recently I just had one DK and coming all the way from 350 kilometers from Vijayawada. And the reason was when I saw the patient, when the patient was going home, I always do 30 minutes of education before any DKA patient goes home. And what I found is that they were using glargine with a massive air bubble. And so they think they were giving insulin, but it wasn't going in. So people think, using the pen is safest, but if you don't pay attention to these air bubbles and practical things, you can push them really into hypoglycemia or decay. So management, don't overtreat. 15 grams of glucose is enough if somebody's glucose is between 54 to 70. If it is less than 54, you may want to give 20 to 30 grams. And you wait for 15 minutes and see what happens. If it doesn't happen, you keep repeating until you achieve the glucose above 70. And once they are above 70, ask them to have a meal. And they can do normal carbohydrate counting and maybe less than take 1 or 2 units away and give that. And if they're unable to treat themselves and unconscious, do not force things orally. So they may aspirate, things can get into lungs and cause serious problems. So do not force things into their mouth if they're unconscious. So you can use intramuscular glucagon if it is available. If it is not available, get them into hospital quickly, give IV dextrose. And there are people in some other countries, not in India, where some preparations may be available called glucose gels, which could be absorbed from the mucosa. I'm not sure if it is available in India. At least I haven't seen. Maybe my colleagues can throw some light on it. And also you can predict hypos. For example, somebody is going for a prolonged exercise. It's important that they check their sugars before they go on exercise. And if it is around 70 or 80 or 90, it might be a good idea to have 1 or 2 biscuits and go for a exercise. Otherwise, they're going to have a hypo. So sick day rules. We're going to speak about sick day rules, what we do. So let's look at this document. So somebody is unwell, having COVID symptoms, and they're giving multiple daily insulins, and you keep checking glucose every 2 hours and ketones every 2 hours. If the ketones are present and more than trace in the urine, more than 1.0 millimoles on blood test, and blood glucose is raised about 250, to drink every 1 hour 100 mils of glucose-free fluids. And you keep checking every 2 to 4 hours. And you can also use correction doses based on their correction. And test blood glucose and ketones every 2 hours and calculate total daily dose. You could use 10% of the total daily dose as correction. So if it is ketones 3 plus or 3 millimoles on the blood test, you could use 20% of total daily dose. And you keep doing that until you achieve the normal glucose readings. And if they're continuously vomiting, and if they're having ketones persistently, despite, usually I recommend blood ketones because the urine ketones continue to be positive for a very prolonged period of time. So if they're vomiting 4 to 6 hours after and persistently glucose is about 250, and if they're unable to take are feeling very unwell and respiratory rate is going high, I think they must visit the nearest hospital where they can get intravenous insulin and fluids, because they may be ending in diabetic ketoacidosis. So even if they're vomiting, most important thing is for them to let them know that they must take insulin. They must never stop insulin, particularly basal insulin. During illness, they may even need to increase the basal insulin by at least 20%. So the most important thing is giving the basal insulin and giving the correction doses and monitoring. And if things are not getting in the right direction, get them into the hospital. As simple as that. So we can go for discussion after Usha's talk. Thank you very much.
Thank you very much, Murali. And that was a quick presentation of hypoglycemia and sick day rules. Can I just say to all our audience, we've sort of pitched these, we've not done things like, for example, diagnosis of type 1 diabetes, or things like what is a hypoglycemia or symptoms of hypoglycemia, because we're assuming that most of the audience have seen type 1 diabetes and are familiar with it. But please, I'm going to save a lot of time for discussion. And if any of you have any specific questions around any confusions about diagnosis of type 1 diabetes, or any questions about, for example, how to recognize a hypoglycemia, not just to manage, and any questions about anything else at all related to diabetes type 1, please post it in the chat box. I will take about 10 to 15 minutes of your time, and we'll come to an open Q&A session. And we'll anything and everything under the sun that you want to ask about type 1, we'll go for it. So right now, I'm going to start sharing my screen and just take you through an introduction to carbohydrate counting and an introduction to technology. Both of these have been mentioned by both Dr. Murali and Dr. Prasanna so far. And the reason this is important is because for type 1 diabetes, see, the pathology is such that they have absolute insulin deficiency. We know this. And we know that the main component of their meal for which they need insulin is their carbohydrate. So if you can teach someone the basics of what is a carbohydrate, to recognize a carbohydrate, and then to understand that the insulin they take must be proportionate to the carbohydrates they're eating, it's very liberating, and they can start eating pretty much, obviously within the limits of healthy eating, pretty much whatever they want without major restrictions. That literally is carbohydrate counting in a nutshell. The advantages is it is liberating. It just lets your patient choose their food and dose their insulin appropriately. Now, goals of nutrition therapy, whether for type 1 or type 2, are literally to let your patients get the best in terms of their health. And with specific context to diabetes, it is to manage their glycemia, their blood glucose levels. If you look at what we are trying to achieve in diabetes, both type 1 and type 2, we want to maintain near normal blood glucose levels, get good weight, lipid levels, safe pregnancy planning, which is very important for our younger type 1 patients. And obviously, like Dr. Murali was saying, a mismatch between food and insulin can cause hypoglycemia. So we need to teach them how to eat healthy for that. And again, he mentioned exercise. So not to have a mismatch between food and exercise and insulin, and to obviously limit the comorbidities. So it is to promote a balanced nutrition, allowing them to lead as normal a life as possible, and to optimize overall health and minimize comorbidities. Now, we intervene at multiple stages: when they're diagnosed, when their control is not great, when they gain weight, when they go on to a change in their insulin regime, or when they have other comorbidities. No society in the world recommends a perfect split between what is micro and macronutrients. But broadly speaking, we know that there are a variety of eating plans available. In terms of macronutrients, we have three main groups, as you know: carbohydrates, proteins, and fats. I'm not going to be talking about proteins and fats, but I'm happy to take questions at the end about anything you might want to ask me about proteins and fats as well. Now, carbohydrate counting, the advantages, as I said, it just counts the carbs in the meal. And once they start to recognize what is a carbohydrate, they can practically work in any food into a meal plan, right? And this little image at the bottom is basically what it is. If they can learn to balance their carbohydrates, they can learn to balance their insulin. That's it. So they can keep track of the amount of carbohydrates. They can take whatever they want to eat, and they can match the insulin to that. Now, whenever I say whatever, I'm obviously talking about within a healthy eating plan. The amount of carbohydrate, as you know, determines how high your blood sugar goes, and the carbohydrate begins to raise within 15 minutes. The blood glucose reacts within 15 minutes of eating. So what you ideally want to do is match a short-acting insulin to the kind of carbohydrate. Now, when you think of carbohydrates, quite a lot of our patients stop at rice and maybe roti. But what we need to understand is that the three main groups of carbohydrates, sugar, starch, and fiber, are present across a variety of foods. Now, obviously, sugar in fruits, fruit juices, or sugar as we add all colors. Now, a lot of my patients ask me, okay, I'm not eating white sugar, but can I eat cane sugar? Can I eat natural sugar? Can I eat brown sugar? Can I eat jaggery? Sugar is sugar is sugar. And it affects your blood glucose in exactly the same way. And naturally occurring sugars in fruit. So people say, I'm not eating any rice, I'm having only fruits. Remember, that's also natural sugars and it will affect your blood glucose. Starches from vegetables, grains, all kinds of cereals affect your blood glucose in the same way. Now, I'm talking about grains and lentils and cereals because a lot of people again think just rice and roti. But please remember, all vegetables have some amount of starch. Things like potatoes and sweet potatoes have more carbohydrates. Things like maybe broccoli and beans have less, but all have a little bit. Legumes, including our all kinds of dals and all kinds of pulses, have carbohydrates. Grains like rice, oats, ragi, wheat, everything has carbohydrates. And obviously processed foods, breads, pastas, noodles, cookies, biscuits, chips, everything has carbohydrates. So learn to recognize carbohydrates wherever they occur and learn to adjust your insulin to those carbohydrates. For ready-made foods, the best thing you can teach them is to read off the serving size and the amount of carbohydrate and fiber in the foods. So for packaged foods, teach your patients to read the labels. And remember that fiber in large quantities is actually very good. And if you have a high amount of fiber, because it doesn't convert to glucose, it can actually slow down the absorption of your glucose and stabilize your blood sugars. So encourage fiber, but decrease your ready starches and ready sugars. And remember, don't forget the hidden carbohydrates like in milk and curd and sauces like ketchup and all the other sauces that they add. So all of these will have carbohydrates in them. So when you're teaching your patients to carb count, remember that all these count. Now, when you have carbs, there are a lot of myths. People assume that because they don't eat rice or because they only eat brown rice or red rice, for all practical purposes, per 100 grams, whether you have rice or you have wheat or you have millets, practically all of them have approximately the same amount of carbohydrates per 100 grams. And again, remember the myths I told you about sugars. All of these sugars have the same kind of effect on your blood glucose levels. All carbohydrates have the same amount of calories. The glycemic index can differ by the amount of complex carbohydrates that are there, including the fiber. But remember, the key is to limit the portion sizes. These are the concepts you need to introduce to your patients. Now, I'm going to just briefly give you one of the quickest ways of teaching your patients to eat healthy, even if you don't have a dietitian in your clinic, is this. Tell them that half of your daily intake should be vegetable and fruit, about a third grains, and about 20% protein with a little bit of dairy on the side. Healthy oils, water, whole grains, and all these are available online. I'm putting the links in the slides. Please have a look. And effectively, if you have a balance like this, it's called the plate method. You can tell them that it doesn't need to get much more complicated than this. Fill half your plate with vegetables, a quarter or a third with any kind of carbohydrate, and 20% with protein. That should balance them out properly. So in summary, you need carbohydrates. Most adults, women need about 45 to 50 grams of carbs per meal. Most men need about 60 to 75 grams of carbs per meal. Most people need about 150 to 200 grams per day, and you need to divide it up. Indians eat a lot more than that, so you need to try and restrict the amount of carbs, but also move them onto healthier carbs. And in terms of counting, please teach them to count the entirety of their carbohydrates, not by just the complex carbs or the fiber. So a lot of people will look for the sugars on the package. It's not just the sugars that will affect their blood glucose. If they're eating a biscuit, it's the total carbs that will affect it, not just the sugars in the biscuit. Now, technology, I'm going to be even briefer. Dr. Murali and Dr. Prasanna have both mentioned monitoring and pumps. Now, you can do self-monitored blood glucose, and both of them have said that at least 1 to 7 to 8, including an overnight reading, depending on whether you want to drive your Mercedes or you want to take a auto rickshaw, your control will depend on how frequently you're monitoring. But you do have fancier technologies. You have, as I said, this is one way of doing continuous glucose monitoring. There are a couple of others available in the Indian market. This is called a flash glucose monitor. And then insulin pumps, which are like a small deck of card size. This is the size of an insulin pump. Now, what are the advantages over a CGMS or continuous glucose monitoring compared to a finger stick? Even in somebody who's checking fasting before lunch, after lunch, and before dinner, you can have readings that seem to be okay, but then you're missing the pre-lunch low, the pre-dinner low, and maybe a post-dinner low, the lows and the peaks in between. So what you get with a CGMS is a more continuous graph and a trend, and you will pick up these overnight. Remember, Dr. Prasanna said the 2 a.m. readings that you must do, you'll pick these up. Dr. Murli also mentioned dawn phenomenon, where you can have an overnight low but a morning high. All these things you will pick up on a CGMS, because most CGMS meters, depending on the kind that you use, will check your interstitial fluid glucose between 5 and 15 minutes. So you'll get a reading very, very, very frequently, and you'll get beautiful graphs. Now, insulin pumps, again, I have to say, are only useful, again, Dr. Prasanna said this, with the right kind of usage. They are not a cure-all. There are some advantages, there are some disadvantages. Now, supposing you have a patient on any kind of a long-acting insulin, you inject it, that's it. You can't turn it off. They exercise, they eat, they don't eat, the insulin is there is a risk of hypos. But with a pump, anybody who's used an infusion set, if you've ever used an IV infusion set in a CCU or ICU kind of condition, it is approximately the same principle, that you can increase it, decrease it, and it responds very quickly, except that the infusion set is subcutaneous, not intravenous. You deliver a basal rate, and whenever they eat, you give a little bolus. You can turn down the basal rate, you can turn up the basal rate, and you can adjust it much more precisely. The advantages are, it lets your patient be fully autonomous and take control. But the disadvantage is they must be autonomous and take control. It's not something you can do for them on a day-to-day basis. It gives them a great amount of flexibility. You can give them various boluses. So for example, in your patient, if they're injecting pre-meal, one bolus, that's it. But for example, with a pump, you can give a divided bolus. You can give a bolus that spreads out over 4 hours. There are various ways of adjusting your boluses. And for illness, for exercise, for stress, for menstrual cycles, you can increase or decrease the basal temporarily or for a day or two. And this dawn phenomenon that Dr. Murali was talking about is very, very, very difficult to manage with an overnight basal insulin, but very easy to manage with a pump. Now, if any of you have a doubt as to what is the dawn phenomenon, we'll take it up in the discussion. Please feel free to ask. Now, there are certain things that are easier. So managing blood glucose around exercise, treating highs, treating lows, for shift workers, overnights, making meal times easy, especially for children who may or may not eat, may or may not be eating on time, may eat slowly, all these problems is much easier. But it is not a put on a pump and disappear. You have to manage expectations. A lot of patients think you give them a pump, the pump will do all the work. Actually, no, they have to do all the work. The pump is only a delivery device. For people who don't want to be attached to something 24/7, a pump is not really a solution. And Dr. Murali has showed you how important it is to manage sites and pump locations, because otherwise you can get infections and other complications. So we have a variety of options. We have carb counting, we have technology, we have a variety of options to make life for a diabetic easier. But all of it depends on your education, you interacting with the diabetic and making them aware of their options and educating them to be able to manage their diabetes independently. So I hope we've just over the last 40 minutes given you a quick trot through the complexity and a brief introduction to type 1. And now we'll just take questions. Before I go into the questions, I really want Dr. Prasanna to tell us, because one of the main things for type 1s is that monetary disadvantage, being not able to afford the insulin, get the insulin, and he runs an amazing scheme for kids. So I would like Dr. Prasanna to tell us all the various methods by which kids can obtain insulin if they can't really afford it. Dr. Prasanna?
Thank you, Dr. Usha. This is $1 million question, because one can give, it is like MBA. You can give any example, Iacocca, Ford, Infosys. But when it comes to that, what works with Narayan Murthy may not work with me. What works with me may not work in Chhattisgarh or Dibrugarh or anywhere. My own example is 1995. I had 5 children. I was struggling how to give lent and plain vials and syringes. Today, after 30 years, 2,500 children, 53. My basic thing is, once you have a mission and a vision, money is not a problem. Even in this country, money has never been a problem for any good things you do. You start with an idea. Tomorrow somebody will come, Madam, I'm going to give 5,000 rupees or 5 lakh rupees. Do you have children? No, I have only 5 children. Sorry, I cannot give you. So first is create that awareness and have it. And what I did was 5 children, 95, 1 center. Later on, from 93 to 2010, for 20 years, I did clinical research. Clinical research gave me not lakhs, crores. At the end, I told my colleagues, this is not my money. The money I earn is not mine. It is from the society. I am only a trustee caretaker. I said, none of us will take 1 rupee, made it a endocrine diabetes research trust. And these crores were kept. We started using the interest. Then now interest from 12 has come to 4%. I said, don't worry. Let us spend all this money in 5 years. Use that interest plus capital. It is stupid today to say, keep the capital, use the interest, it is dwindling. And then somebody came and said, sir, we have got CDIs. He said, changing diabetes in children. We want to give 4,000 children. 800 children I could put it. Last week, somebody came, sir, we want to do 2,000 children. We have recognized 40 centers. They have 30, 40 children. Within 2 days, I gave the list of all children, Aadhaar card, income certificate, their dose, and they said, we'll give you next 3 years for 30 children. That comes to almost 1,200 per 3 months, 1,20,000. So for 4 quarters will be 4,80,000. Okay. And for 3 years, maybe 15 lakhs also. So why I'm telling you is, you started, every one of us doctors, forget others. We have patients who are rich. What do they say? Every patient I talk to them, look here, your son is fortunate, you are rich, you are giving insulin. There are other 2,000 children who are poor. Sir, tell me what I want to do. No, I don't want money. I said, never give me 1 rupee also. You want to help a child? Here is a child, talk to them. What do you want to do? Instead of giving 100 or 1,000, you say, okay, I will take care of these children, I'll buy insulin for him, syringe for him, glucometer for him. In fact, somebody gave me insulin pump worth 5.5 lakhs also. So the model is, if you are a doctor taking care in your center, talk to every patient, whether it's type 2 or rich or whoever it is. There are unfortunate children who have got this. I never ask money to anybody. That person will say, what can I do for you? First tell him, don't give money. Come, I have got Sundays 10 children. Come and talk to them. Ask them what are their needs. Somebody may say exercise books. It may be education and health giving. By that, lot of people are discouraged, don't give money. Somebody came from UK, I want to do something. I don't want your money. Let me finish all my money. Then only I will take money from you. Then what shall I do? Come there, talk to the children what they want. Give it directly to the child. He feels happy that the question today is not a poverty in this country. Richest of the rich are there in Asia and India. If we give 1 rupee to Dr. Prasanna Kumar Usha, will it go to the poor people? That is their question in the mind. If they are convinced that giving 1 rupee to you will definitely reach that child, they will open their purse. Not that Dibrugarh, there are poor people, 50 centers in Karnataka. I tell everybody, look here, someday you have to become independent. I tell children that, uncle, give me that. How old are you? 20. Then what have you studied? BA. Are you married? Yes. Why do you ask till you become children, grandchildren also? As long as you are studying, I'll give you. Once you study, you are working. Now you should come and say, uncle, I will support another 5 children. Like that, people have been supporting and all. This is the model. I built a 5 crore rupee hospital for type 1 diabetes. 100 children were coming every Sunday. Ask somebody, what do you want, sir? 100 chairs. Give me quotation. He said, I know you don't have 100 children. I will give 100 chairs. He didn't ask me money. Then somebody said, I'll give breakfast and lunch. So we are getting 100 breakfast, 100 lunch. Every doctor in Bangalore was coming once in a month, one Sunday, and treating these children. Men, material, absolutely no doubt. After running it 9 years, I left that 5 crore hospital, walked out of it. So it is easy to create, run, easy to walk out also for the next generation to carry. That is how your attitude should be. And most important, make yourself dispensable. If I am not there tomorrow, all these 52 centers will run. It is the local doctor, endocrinologist, pediatrician, adult endocrinologist, American trained, UK trained, they are all managing that. None of them are run by GPs, even physician also. Diabetologists, endocrinologists are managing. 8 pediatric endocrinologists. That is the model you have to start. There is no dearth of money. If you have inclination, time, vision, and mission, money will flow. Don't worry about it.
Thank you very much, Dr. Prasanna. So there are foundations like Dr. Prasanna's which can provide insulin. All of us can also help. And there are also certain pharma companies that can provide insulin free of cost to your young type 1s. So in case you have anybody who you think can't afford insulin, please reach out. There is plenty of help available. We have a few questions from the audience. I'm going to put the first question to Dr. Murali. They're asking, Murali, what is the minimum range to start 25% dextrose? This is from Dr. Surajit Debarma. What is the, in emergency rooms, what is the minimum range to start dextrose? I'm assuming they mean at what CBG would you consider starting 25% dextrose?
First of all, one thing I have observed is being in Manipal Hospital, every hypoglycemia is treated with 25% glucose. Okay, first of all, that's wrong. So we only give 25% glucose for the people who cannot actually take orally. So if somebody is comatose or somebody is low GCS and giving orally is dangerous because they may aspirate, that is the only time we give glucose, not based on the GRBS level or not based on the plasma glucose level. It is the degree of conscious levels, or if the patient is vomiting and insulin has already gone in and has a hypoglycemia, that's when you want to give 25% dextrose. Apart from that, I don't see any reason to give 25% dextrose. I can tell you in my entire life, I probably gave 25% dextrose maybe 2 or 3 times a day. And in my entire life, 14 years.
So I think that's, the sensible thing to do. I just want to add one more thing. See, when you have hypoglycemia, a lot of people panic and think time is of essence. But remember that when you have hypoglycemia, you have stages. You first get the adrenergic symptoms, which is the shaking, shivering, sweating, hunger, these kind of symptoms. Those occur even around CBG, depending on the control of anything from 70 to 80, 90, even some people higher than that. This per se is not dangerous for the person. It is only readings that get to around 50 that pose a danger, and you have a time between the 50 and the 70 where you can actually correct orally, as Dr. Murali said, without needing to reach for the intravenous dextrose. Intravenous dextrose, as he correctly pointed out, is where patients can't take by mouth. So it's not a CBG level, but the patient's clinical status that determines it. Dr. Prasanna, there is an anonymous attendee who's asking, how often do you advise type 2 to check blood sugars? We've talked about type 1. They're asking about how often do we advise type 2 to check blood sugars?
See, every type 2 diabetics need not necessarily have glucose meter. The reason is many of them are hypochondriac. A lot of them retired, no work at all, go on doing everyday blood sugars and then say, doctor, it is 98, 128, 190. And why is it not stable? You tell them you have never monitored. Now you monitor and know how it is unstable, even in type 2. It is like a bald man having a mirror and trying to look at mirror being beautiful every day. What is the point into it? Somebody who is not on any drug which causes low sugar, right? Somebody who is only on lifestyle modification, don't buy. The unfortunate thing, one daughter from America, another daughter from Canada, Australia, they have 3 glucose meters. They don't do anything, sir. You do the blood test. After that strip is over, they will never buy the another strip also. This is the problem what they have. But those who are on insulin, the moment a type 2 diabetic takes insulin, he must buy glucometer, he must check. Now we ask them, at least because you don't adjust the dose daily. It is like a mirage. Chasing a mirage is useless. I tell them, if possible, minimum twice a week or maximum 3 times a week, check blood sugar. And if it is good, don't send every day, send it once a week. I have 5,000 patients on e-consultation. They send the report, 60. One person in 4 years has sent 180 consultations, 180 consultations. And his control is excellent. Why? Because he monitors 75-year-old fans and he's so much there. And other people, months together, they don't. Those who are on tablet, ask them, check once a week because meter is there, strip is there. Once you open the bottle, if you don't use it in 3 months, the air gets in and they'll be using after expiry date. 1 year, they'll be using it. Sir, it is showing 70, it is showing 100. So this is the problem, educate. And there is nothing like any consensus, ADA, yes, IDF, even RSSD, how frequently to do blood sugar. Only those on insulin as frequently as possible. Some people say, I can't check fasting. I always ask them fasting, pre-lunch, pre-dinner. And sometimes I say, all right, one thing you do, you stagger it. Monday you do 1 blood sugar, Tuesday you do blood sugar, Wednesday fasting on Monday, pre-lunch on Tuesday, pre-dinner on Wednesday. Next time, Thursday, Friday, Saturday, you check 2 hours after breakfast, 2 hours after lunch, 2 hours after dinner. As Dr. Murali said, it is impossible to control all 7 blood sugars. Once he sees, he gets worried. Doctor, my 2 hours is 202. My pre-lunch is 110. Fasting is 95. Sir, there is no medicine on the earth to make your 24-hour blood sugar control. This is to educate you how it goes. At least if he checks 2 hours postprandial is high, what did you take? As you said, carb counting. This is the patient to say, look here, this is a mistake you are doing. You think you are taking fruits or vegetable or ragi or organic food and all, or some rice which takes away all glucose. Very, very popular in Andhra. This is a rice where we have taken out glucose, 150 rupees per kg, you can eat any amount. Now you see with that rice, 150 rupees says what is 2 hours. Then I can educate him to change your diet or exercise to see how it flattens. This is how it is individualized. There is nothing like a universal. We have been involved in many of them. How frequently to check? There is no one statement for all. As frequently as you can is the answer.
So in somebody who's very well controlled or on drugs, less. In somebody who's badly controlled, if we can motivate them as frequently as they can till we get good control.
Perfect.
Yeah. So we have another question, and I think this is a slightly more personal question from Dr. Ketan. He's asking that his son, and I'm assuming that his son has type 1 diabetes, is unable to cycle or play with other children because his sugars are fluctuating, sometimes 350, sometimes 80, 110. And he's asking how. Now, Dr. Ketan, I have to say this is possibly not the forum for one-to-one advice, but I think I'm going to ask both Dr. Murali and Dr. Prasanna to talk about exercise in general and adjusting the blood glucose levels. Maybe Dr. Prasanna with the basal bolus and Dr. Murali with a pump. Maybe you could both help sort of clear up this question, please.
Yes, basal bolus is the best one because, as I said, if you try premix and all, you can never have a good control. In fact, I have 4 patients who have used pump 1 year to 10 years. Control went haywire, 9 to 10%. I said, stop it. Maybe continuous insulin there is causing antibodies. They changed to basal bolus, perfectly all right, 5 years. So don't think insulin pump is for all. If you can manage good basal bolus, fine. In USA, it's a different issue. If you take the shots, 70% of his patients are pumped. Neither our patients can afford it, nor it is available, nor acceptable. Very rich people. The moment I say pump, child says, no, uncle, I don't want pump. It is not that pump is attached to them. They feel they are attached to the pump. So that is why when you do basal bolus, try to correct it with insulin. And as I said, many people say, doctor, when I got up morning, it was 130, I'm happy. Okay. I go for a walk, come back, it goes to 160. I thought after exercise, blood sugar will come down, it is increasing. This is called paradoxical response. Why? Because when you do exercise, the glycogen, which is a stored glucose in the liver, is now thrown out after exercise. So some people after exercise, blood sugar goes up. A long-term effect of exercise is the muscles will take more glucose comes down, but there may be paradoxical 3 to 5% of type 1 or type 2, where you see hepatic glucose output increases after exercise, or adrenaline is increased after exercise. All these things will cause that. So more frequently you monitor, adjust the shot. Now, Dr. Murali showed that fast-acting aspart. So some people with long-acting regular insulin, 2 hours blood sugar is high, 4 hours comes down. So in type 1, if they can afford, you can do short acting. I am sure in few days we'll get very, very short acting insulin, which works 1 hour, 2 hours disappear. That will be probably an issue where it will control 2 hours, but you may have to take 5 to 6 times that, 3 times. Over to Dr. Murli about pump.
Yeah, the pump usually my experience in pump in India is not very good, mainly simply because most of the people who got the pump were given as a panacea. Okay, this is going to fix your problems. None of them were taught how to do Daphne or carbohydrate counting. All of them bought the pump thinking that it's going to solve the problem. Some of them even got admitted to hospital with DKA because they never checked it was actually working. So, the photo I posted on my presentation is actually pump girl, where it was causing cellulitis and abdomen. It was horrible. So, if somebody is on pump and want to exercise, how you manage? Well, simple. Whether it is MDI or pump, the principles are the same. Most important thing is checking the reading before going for an exercise. That's one important thing. And if it is lowish, it is definitely going to fall, particularly if you're going to do intense exercise for a prolonged period of time. So that's one thing. And the second thing is, if it is high, do not do any correction before going for an exercise. Don't do any correction. That's one thing. In certain quick, not prolonged quick exercises can actually cause hyperglycemia, immediate hyperglycemia. And then you may be having your next meal and you may have tendency to do a correction along with the carbohydrate counting. If you do that, that can cause problem because usually hyperglycemia that is developed after the exercise do not require correction because it will automatically come down slowly. So you just have to be patient. And the second thing is, if you're using pump, what you can do is you can do something called temporary basal, where we would recommend 20% to 30% reduction of basal rate, which can be activated as soon as you start the exercise. But again, you learn from your experience. So it may work 20% reduction for you. For another person, it may require 30% reduction. So you basically learn from each episode of your exercises. Over a period of time, you develop, okay, depending upon exercise, which exercise you are doing, you will know what is the percentage of reduction you require, and then you adjust the insulin pump accordingly. So that's how you do it on the pump for the exercise.
Dr. Usha, you are on mute.
Thank you. So I hope that answered your question, Dr. Ketan. See, the physiology of diabetes and especially type 1 around exercise is very complex. Depending on the type of exercise, your hormonal responses are different. For short, sharp aerobic exercises, for example, you will have an adrenergic rush and you might see a high blood sugar immediately after the exercise, followed by a low blood sugar later on. For sustained kind of exercise, like for example, marathon running or prolonged sports, you will see a different kind of response where you start using your hepatic glycogen and you might actually experience hypos later on. Not everybody needs a snack at the beginning of exercise. For prolonged exercise, you might actually need a snack 20-30 minutes into the exercise once the hepatic glycogen starts to be mobilized. For exercise that is intermittent, so for example, like tennis or things that have rests and then activities, your pattern will be different. There is one very good website, Dr. Ketan. Have a look at something called runsweet.com. This is started by a UK endocrinologist. He has a lot of top Olympic athletes and other type 1s who are under his care. And essentially, he looks at exercise bite pattern and explains to you how each different exercise can affect your blood glucose levels. For your personal use, please look at that. And if you would like to discuss one-to-one, please reach out to me by email. I'm happy to have a chat with you. Now we have another question. How do you calculate the dose of insulin in diabetic ketoacidosis? This is coming from Dr. Snehalata. I think, again, I'm going to split it into two parts. Dr. Murali, would you maybe just talk for a minute about how to recognize DKA? And then I'm going to go to Dr. Prasanna about the regimen and the protocols available for DKA.
So identification of DKA is simple as that. Simple. Usually, if somebody is unwell or new, people who were never known to have type 1 diabetes, coming into hospital being very, very unwell with fast breathing, nausea, vomiting, abdominal pain, and if you carefully take history preceding to that episode, they might be having some polyuria, polydipsia, and significant weight loss. And so often when you see the patient coming into hospital with DKA, you see this Kuzumal breathing. You see the patient, you straight away know this patient is DKA. So they're extremely dehydrated and they have a tachycardic, tachypneic. So they're very unwell patients. So as soon as you recognize the DKA, as soon as you see, look at the capillary glucose very high, and you know this patient, based on the clinical science, this is a DKA. You immediately check ketones and things, but most important thing is you get the line in and start insulin and give the fluids. So that's one thing you need to do first, and then you can work it about ABGs and all other bloods, and you can wait for them. So if you want, I'm not sure how often ketones sticks are available here. Even in the very beginning, I had very difficulty getting the ketones. So you make a clinical diagnosis based on the presentation and high glucose readings, and you just, you have to be aware of euglycemic DKA as well. And I have seen type 2 diabetes patients presenting with euglycemic DKA. I had at least 4 patients in the last 1 year. Type 2s presenting as DKA after having diabetes for nearly prolonged period of time, just after missing just 1 dose of mixed insulin. So we have to be aware of that as well.
So I think one thing we need to remember is any unwell type 1 diabetic is a DKA until proven otherwise, I think you have to prove that they're not in DKA and treat them as a DKA by default.
Yeah.
And once you're convinced it's not a DKA, you can always de-escalate, but it is very, very, very life-threatening to miss a DKA. Dr. Prasanna, especially in India, the protocols for treating DKA are so different from even doctor to doctor. How would you suggest is an easy approach for most of our colleagues to sort out, see and treat a DKA?
My DKA management started from MBBS 1970, MDs in 78, DMs in 85, and today. If you see Alberti's regime, we were all reading as students, Alberti's regime. Before that, high dose. Talking about history. My teacher said, give 50 units of insulin intramuscular, 50 units of insulin in the drip. Now from that, they said, no, low dose insulin is what you start with, 1 unit per hour. Now then low dose is gone, high dose is gone. Then the modified Alberti regime, that in mind. You are asking the right question to a wrong man, because if you ask me, when did I treat the last diabetic ketoacidosis? 2009. 12 years I have not treated one diabetic ketoacidosis. I am proud of it. I am not unhappy. If you have 2,500 patients and somebody presented, we have a large one, 250 patients of DK 1 year. I said, thank you, sir. You are the worst hospital in the world because you are getting only ketoacidosis. You are not managing any type 1 at all. Unlike what we used to do 40 years back, patients come at morning 10 o'clock to evening 8 o'clock, walking patient, A1C 15, blood sugar 500. Do you have nausea? No, sir. Do you have vomiting? No, sir. Start insulin. Take this glucometry. If we are proved everything, you take it. I will teach you next 45 minutes. Don't get admitted to hospital. Every day, 3 times you do, finish it. Only occasionally, as I said, one of my patients, small child, went down to 12, 16, 18, 20. I said, come tomorrow. I want to check. And after 20 days, he said, sir, had ketoacidosis. As Dr. Murali said, I could not get any ketone body strips. As I told you, we had keto sticks, keto diastics. I don't know what they have today. I am agree with Dr. Murali. He said, nobody taught me about it because not available and not the problem. So the dose today, I have used pump when I was in this one. My best thing is anybody admitted, please remember one thing, it is not insulin deficiency that is important ketosis. It's not deficiency of insulin which is going to kill a patient. First thing is correct the hydrosis and dehydration, correct the electrolyte. People die because of these two things, not because of insulin. Insulin is not the first thing to do. Just check, is it dehydrated? Run proper amount of saline. Dr. Mulde has given already the protocol, how much of saline to give over hour. It's not that 10 drops per minute, 20 drops per minute. You have to give 1 to 2 liters in the first 2 to 3 hours. Correct hydration. Correct electrolytes, more important. If they have hyponatremia, hyperkalemia, that is going to kill. The next thing is find out the cause. What is the cause? Infection, treat. The third thing is, probably fourth thing is insulin. Now remember, in ketoacidosis, subcutaneous insulin does not count. Now people have used drip, putting 50 units, 6 units, all sorts of things. Best thing is, I've seen all these protocols. Every institution or individual should have its own protocol. What works in Dindigul, it is different from Apollo Hospital in Chennai or Bangalore. It depends what availability you have. You have only one drip saline. You have got only one insulin short acting. Does not matter. You don't have to look for analogs at all. Short acting insulin. Never use premixed insulin, long act, because I've seen many people doing that and putting in a drip. It is useless. Then what is there? Nurse is there, monitoring is there, electric. Nothing is there, sir. Even if nothing is there, if you are a good clinician, you can manage it. Many times what you do, run saline on one side and run insulin drip on other. Why? Because you think, okay, 6 drops per minute, you have put 50 units and then say 6 drops. And nurse says, no, increase that. She is increasing the drip without knowing that it contains insulin. I always prefer 2 separate lines, one for saline and another for the insulin. Now you start giving small dose of insulin, whatever it is, 3 or 4 units per hour, depending upon the age and weight. I don't calculate depending on the weight. Look at every hour. I have seen in a setup where no PG, nothing. I had a SSLC, a boy who was type-1. I said, sit here next to the patient, take this glucometer bottle. Every hour you do the blood sugar, tell me that. By morning, it should be 120. Otherwise, you are going home. Every hour he did, he adjusted the dose, he got it. Many house surgeons don't know how to adjust it. This SLC boy type-1 did it for 6 years. When I got a pump in 1990s, the same fellow I said used to put a pump. Nobody in Ramaya College, physician, PG, house surgeon, or my colleagues didn't know how to use a pump. This boy knew, sir, I'll put the pump intravenous pump. No question, drip on one side, pump on another side. That is how I used the first pump, my Fuser pump, costing 10,000 rupees in All India Institute. There were 3 pumps in All India Institute. Nobody knew how to use it. After I used it, finally we had a girl, Shaban, I remember her name. She was on insulin pump IV 6 months. 400 units per day and subcutaneous never worked. When we put her on IV pump, with 40 units, it was well controlled. 6 months she was on insulin, she died with it. This is one stage where you see resistant to subcutaneous insulin, responsiveness to IV insulin, meaning that IV insulin always works. In ketosis, remember IV insulin. Remember IV insulin. Remember regular insulin. Does not matter whether it is analog or a simple plain insulin, does not matter. And what you have to do is every hour, the drop of insulin should be at least 50 milligrams per hour. If the blood sugar does not drop by 50 milligrams per hour, double the dose. I start with maybe 4 units per hour. Then if you see does not increase 6 or 8 units, and you have to do that. Otherwise, go on giving 1 unit per hour, it will never come down. Even next day also, they will be ketones. As Dr. Murli said, best thing is not to manage only on urine ketone bodies. Many people keep the patient in the hospital till urine ketone bodies come down. It may not come down 5 days. If we can do serum ketone bodies, even beta hydroxybutyrate, that will be fine. Today, there are meters where you can directly check the ketones in the blood. You don't have to do urine at all. So depending on facilities, tertiary care, secondary care, insulin pump, dedicated nurse, PGs are nothing. There is a village and only thing available is saline and you have insulin. You can manage, provided you sit next to the patient. You have glucose meter, drip, you can manage it so well. Whatever you may say, 2 units per hour, 1 hour unit per hour, 2, 3 units, nothing. Because nothing will happen with that. The half-life is less. Every 10, 15 minutes you can check. You don't have to wait hourly. But once you start 1 to 4 units per hour, usually 2 to 4 units I give per hour, the drop should be minimum 50 milligrams per hour. Otherwise, double the dose. So that in 6 to 8 hours, you can control any blood sugar to, you don't have to bring it normal. Keep it below 200, you have done the job. Later on, you can do other things. This is how managed. Don't ask me which regime, whether it is Albert's regime, Prasanna Kumar regime, depending upon what is available, I do from rural area bedside to tertiary care all India Institute.
So that is exactly where I wanted to come to you, Dr. Prasanna, because if you look at DKA regimen, yes, for a situation with perfect facilities, you have regimen that talk about monitoring the potassium every 4 hours, monitoring the CBG, giving IV insulin infusion using an Alaris pump for IV insulin and fluid. Everything the protocols and the guidelines are for hospitals that have all the facilities. But DKA can be managed with nothing more than fluid, potassium, insulin, and a CBG meter. You can do it. Subcut doesn't get absorbed because most of these people are dehydrated and shut down and don't really have good absorption. But I think one of the things, you will correct me, Dr. Prasanna, but I have seen long ago DKA even being managed by intramuscular insulin where subcut doesn't get absorbed. You give a bolus of intramuscular and then you run the fluids and correct the potassium and they manage. So you don't need much more than the basics, right?
In fact, there is a paper to show every 2 hours give intramuscular because some of them come in shock. Your IV does not work. What is the situation?
Yeah.
When the patient comes in shock, don't use IV. You may not get a vein even if you give useless. That is a situation you can give. In fact, All India Institute, we have managed many cases where every 2 hours we are giving 4 to 6 units of intramuscular insulin because IV fluids we cannot push. We have to put central line and manage it. So that is how, as you said, depending on situation, IV, IM, whatever. But IM is always inferior to IV, though one paper said it is as good. But if you don't have IV line, don't hesitate with it. But you have to manage fluids, and we don't have potassium. What were we doing in 1980? Do ECG every 2 hours. That is our criteria of potassium. If I give potassium today, I was getting result after 16 hours. We didn't have in a government hospital that electrolytes, and we have got all these facilities. So our way of knowing potassium was ECG. All of us have been taught how to make a tall T wave. Today, nobody bothers about it. So we are from the medieval times, we have managed all this with minimum facilities. So that is what everybody has got knowledge. What is necessary is wisdom. Wisdom comes from experience.
So if your T wave height is decreasing, your potassium is decreasing.
Yes, exactly. That is what we were doing 1975 to 1980. I had not seen electrolyte reports at all those days with all that. Send today, tomorrow evening, you will get the report.
One thing I have noticed is one mistake that commonly being done even in big places is giving bicarbonate. As soon as they come into ER, they give bicarbonate, that having very severe hypokalemia later and very difficult to bring it up later. This is something I've been observing.
So fluids will mostly take care of the acidosis without needing bicarb.
So that is why guideline says unless pH is below 6.9, never use bicarbonate. In fact, many people have died due to bicarbonate rather than saving lives, because that is what used to be there 50 years back. Blindly, they said 20 ml of bicarb. God knows how many of them died due to cerebral edema and other things. Nowadays, they say because everywhere you have pH meter, within minutes you get it. So that's why you don't give anything more than 6.9. Don't give bicarbonate. That is how the guidelines have become much better compared to what we saw 70s and 80s.
So I'm going to just quickly answer this final question. Dr. Surajit Devarma is again asking, any specific treatment protocol for type 1 with COVID infection? Actually, Dr. Surajit, there is no specific separate protocol, but remember that when you give steroids for either type 1 or type 2, your insulin requirements, the doses will be huge. So just chase the sugar levels with adequate doses. Now we have about another 3 or 4 minutes, and I have no further questions from the audience. So there are a few things that I just want to flag up. Look, during this, we have talked about variety of things, but bottom line is, for managing type 1, it is not technology, but your expertise and familiarity and your ability to spend some time. Dr. Prasanna has said time and again, spend half an hour and to educate the patient to look after their own diabetes. You have U40, you have U100. Make sure that the syringe matches the insulin that you're giving. You have pens, you have cartridges. If you're going to use pens and cartridges, please make sure that you teach your patients about the correct technique so that they're not left with big air bubbles that they're injecting rather than using up the insulin. A simple way of checking whether they're taking insulin or whether their insulin is going in is to check how many days their pen or vial lasts them. And remember, as Dr. Murali said, not all hypos need IV treatment. You need to educate your patients to be able to manage these hypos orally, and then if necessary give IV in an obtunded patient. And there are many ways in which you can get insulin for your type 1 diabetes patients. So with that, I'm just going to ask for any final words from both Dr. Prasanna and Dr. Murali.
Basically, type 1 diabetes management is a specialty. Everybody can treat type 2 diabetes, MBBS, MD, DM, American board, UK board, everybody. But to treat type 1 diabetes, you should have knowledge, expertise, more than that, experience. If you have not treated 10 or 20 type 1 diabetes, never venture to do it. Even after 35 years, I cannot claim I am an expert. I am the best in typing management. Every day I am learning. So please acquire the skill and knowledge before you start treating. If you don't know, please refer to an endocrinologist or diabetologist who has a more experience and expertise in managing type
1. Murali?
Yeah, I agree with Dr. Prasanna. One thing I notice is after being here for 2 years, that type 1 diabetes patients have been running around like headless chickens and looking for answers. And many of them are desperate, and some of them are even deceived with malicious intent. Some people have spent lakhs of rupees for life. And I was really shocked when I met how these people were duped. So most important thing is that carbohydrate counting, taking basal bolus regime, and I think these two things are very important keys to the management of type 1 diabetes, and will address most of the problems. However, they require simple things like education, how to use insulins, how to prevent hypoglycemias, if it happens, how to treat, and how they can get in touch with us in case of emergency, because we don't want one of our patients ending up in ICU dead. We don't want that, do we? So at least we should give them a contact number, or if it's not yours, at least a hospital where they can go to in emergency. So that those are the at least the simple basic things that we would need to provide to type 1 diabetes patients. If we are not doing at least those simple things, I don't think we are doing any justice to those patients.
Thank you very much, Dr. Murali. I would like to join everyone for joining us. I can see that the numbers are dwindling, and I'd like to hand back to Dr. Vijay at this stage.
So I would like to thank all the panelists, Dr. Prasanna, Dr. Usha, and Dr. Murli. I really thank you for taking out time and addressing the thing. We had a good number of participants in between, and we also had a couple of people joined through YouTube. So I would like to thank all the participants in spite of their busy schedule. They have been able to make time to understand about type 1 diabetes. And being from the same fraternity, a lot of things was eye-opening for myself. So thank you all again. This would be posted, and we would share the link. This can be further disseminated for whoever wants to have a look at it. And we are also trying to get this as a print media article. If that happens, we will circulate. So we will have a lot of other people benefiting out of this session. Thank you, one and all. Thank you. Have a safe night. Thank you.
Thank you very much.
Thank you and good
Thank
night.
you very much, Dr. Prasanna.
Good night.
Bye bye.
Good night.
Thank you
I
all.
would very much like to thank Dr. Murali and Dr. Prasanna also for taking the time out and obliging me when I said, can we please do this? So thank you very much. Thank you.
Thank you.
Thank you all. Thank you. Bye.
Thank you.